My topic today will be CSF flow disorders related to Chiari malformations, and it's a rather large topic. We'll try to kind of go over the most important ones and try to cover some of how these interface with some of the Chiari discussions, and little bits of this you've already heard from some of the previous speakers. So let's see here. There we go. I have no disclosures. This is a diagram done by Frank Netter, one of the famous anatomists, and he did a beautiful series of anatomy textbooks showing the CSF pathways. And the classic description of CSF pathways, a little simplified, but is that CSF is made secreted by the choroid plexus in the lateral ventricles, third ventricle, and fourth ventricle, circulates through the ventricles from the laterals to the third, through the aqueduct to the fourth, then out the openings of the fourth ventricle, circulates in the subarachnoid space all around the brain and the spinal cord, and primarily gets reabsorbed into what are arachnoid granulations into the superior sagittal sinus predominantly. So this is our classic description of CSF pathways. Now, let's superimpose on this Chiari malformation. This is a Chiari 1 malformation with a holochord syrinx that you can see on a sagittal MRI, where we don't see the CSF space here as well. And there's been a great deal of discussion already about how do you define a Chiari. It's sort of one of those I know it when I see it kind of descriptions. But for purposes of this talk, I just said more than 4 millimeters instead of the 5 millimeter rule. There's a great deal of difficulty, but I think the most important thing that everyone agrees upon is really not so much the number, but the effect on the normal pulsations of CSF flow between the spinal canal and the intracranial space. So when we look at this, and again, this is a very short list of some Chiari signs and symptoms: occipital headache, Valsalva-induced of short duration, so if you cough, sneeze, or strain; numbness or weakness of the hands; signs of brainstem compression, including swallowing difficulty or breathing difficulty; vocal cord palsies, or even central sleep apnea, all of which you've heard about a little bit. This is not an exhaustive list of Chiari symptoms, but just wanted to focus on some of these that seem to correlate also better with how do patients respond to Chiari surgery, what gets better and what doesn't after you operate on somebody. So in looking at CSF flow disorders, I want to think about them in sort of two categories. One is high pressure CSF disorders, and one is low pressure. So in high pressure, we have hydrocephalus or pseudotumor cerebri. You've already heard some about this. Also want to add in low pressure CSF leak or intracranial hypotension, as well as lumbar shunting, which we've also already heard is a treatment for one of the high pressure conditions. So let's start with getting into hydrocephalus. This is a buildup of fluid within the ventricles of the brain. It's present in 4 to 18% of patients with Chiari 1. Most big series will talk about 10%. Hydrocephalus in general is described as obstructive versus communicating. So in communicating hydrocephalus, the CSF can flow through all these pathways, and then it's really predominantly an absorption problem so that the CSF builds up. In obstructive hydrocephalus, there's a physical blockage someplace within the system. Most commonly, it's at the aqueduct, the communication between the third and fourth ventricles. In Chiari, there's also a role of fourth ventricular outlet obstruction or aqueduct obstruction. So is this the tight Chiari at the foramen magnum is blocking the outlet flow from the fourth ventricle? Is the whole posterior fossa tight? Is the aqueduct itself blocked? And what that manifests itself as, again, going back to the Netter diagram, is this is the aqueduct, so there's a blockage here so that fluid doesn't get into the fourth ventricle, or is the blockage down here that fluid doesn't get out of the fourth ventricle. That will have some implications a little bit in terms of therapies, and in fact, we have to even discuss, is a blockage really even the complete etiology of hydrocephalus? So when we think about hydrocephalus on its own, we'll often think of headache, which is often frontal, associated with nausea or vomiting, oftentimes worse in the morning or middle of the night when someone is reclining, because that's when the pressure in your head is highest. Blurred or double vision, impaired up gaze, impairing the ability to look up, or forced down gaze, what's called a sunsetting sign, where the eyes look like the sun setting on the horizon. It's not someone just looking down, they physically can't look up. And then papilledema or swollen optic nerves. treatment of hydrocephalus that we're going to talk about here, ventricular shunting. This really revolutionized life for patients with hydrocephalus with the development of shunts. The idea of a shunt is we're taking spinal fluid and diverting it someplace else so that something good can happen to it. In the case of atrial shunts, you're just taking that fluid and dumping it directly back into the bloodstream where the fluid came from to begin with. In the case of peritoneal shunts or pleural shunts, the fluid is getting to a space in the body that can be reabsorbed back into the bloodstream. So there's another reabsorption process there. For obstructive hydrocephalus, particularly initially at least, endoscopic third ventriculostomy came about. The development of ventriculoscopy really allowed this to take off. So basically what you're doing is, in the case of a blockage, you're basically bypassing that blockage. So you're just creating a place that fluid can flow through. So it's basically like a wastegate around a dam is what we're doing here. Now, hydrocephalus present with Chiari malformations, there was a lot of thought that it's just a blockage of flow at the foramen magnum. And so, again, endoscopic third ventriculostomy, which worked very well for aqueductal stenosis hydrocephalus. Well, if we just do a third ventriculostomy, and I'll show a picture of that in a minute, we are bypassing the blockage down below, and that should really work great. And it works in various series, 40 to 80% success rate, but it's not 100%. And so when we look at that, well, why is that? One of the things you've already heard is that in general, when hydrocephalus is present along with the Chiari, first treat the hydrocephalus, then observe to see if improvement, then maybe need to treat the Chiari. Well, if this is truly just obstruction from the Chiari, the treatment also could be do the Chiari decompression, and that relieves the obstruction. The hydrocephalus should go away. As you've already heard from several people, if hydrocephalus is present and you do the Chiari decompression, very commonly you then deal with the resultant CSF leak from continued high pressure, and you wind up shunting at that time. So the question is the Chiari causing hydrocephalus? Is the hydrocephalus causing the Chiari? And I think really we have to look at treat the hydrocephalus first and then see if you need to treat the Chiari, because in many times that will be enough and you don't need to do the Chiari decompression. But again, Chiari decompression, as you've heard from several speakers already, alone is rarely successful. So when we talk about doing a third ventriculostomy, the classic aqueductal stenosis, the aqueduct is right here, the third ventriculostomy is right here, just behind the pituitary gland in front of the brainstem, creating an opening here so that the fluid, instead of having to go getting blocked here, flows through the opening here into the subarachnoid space. If there's no obstruction here as well, it can flow throughout the whole spinal subarachnoid space and the intracranial subarachnoid space. So that way you basically restore normal pathways for the spinal fluid. Now, you've also heard pseudotumor cerebri or idiopathic intracranial hypertension already mentioned. This is basic, and you've already heard Dr. Trumbull mention that the term brain turgor or stiffness of the brain. If you think about a softer brain with pressure buildup, the ventricles dilate and the fluid accumulates in the ventricles. With pseudotumor, the brain is stiffer. It pushes back and doesn't dilate as much with the ventricles. So you have high pressure, but you don't have ventricular dilatation. Okay, so basically same kind of neurologic findings, elevated pressure on a spinal tap, normal spinal fluid composition, and small or normal ventricles, called idiopathic intracranial hypertension. Now, the typical adult patient that we see this in is an obese female. In pediatric patients, it's often not predominantly female, and it's often not obese patients. They're often skinny kids, which is not nicer to operate on than the obese patients. But if we look at pseudotumor patients, about 6% of them may also present with a Chiari malformation. So this is where the overlap comes in, and that we'll have to look and very carefully examine our patients to see and not miss the pseudotumor. One thing that's also come up is in pseudotumor patients, the stiffness of the brain in many cases is related to intracranial venous hypertension, which is basically, if you think about either a stenosis, a narrowing in some of the big venous chambers around the brain, this is a backup or a backflow. Imagine your garden hose. If you put your thumb over the end of the hose, you increase the pressure. So it's a backup of venous blood. that then that may well be cause for this. There's many studies that show, even if you can't demonstrate it anatomically, that there is a pressure gradient somewhere in the venous drainage system for the brain. So again, we see some of the same symptoms we've talked about, papilledema, elevated intracranial pressure, and the reason the pressure goes up is, again, we talked about spinal fluid getting absorbed back into the blood system, so into the veins. In order for that absorption process to happen, you need the intracranial pressure has to be 7 to 8 millimeters of mercury above the venous sinus pressures. So as you raise the sinus pressures, the ICP goes up, otherwise you don't even have any absorption. So that's why that's an important factor. One other thing we'll sometimes see, it's very important, as several speakers have already mentioned, you have to look at the MRI scans, talk to the patients, and really get a sense of what's going on. But one clue that we'll occasionally see is what's called an empty sella sign. So if we look here, this is the sella turcica where the pituitary gland sits. It's normally a nice round gland. This sella is bigger than normal. There's a bigger spinal fluid space there, and the pituitary gland is kind of flat. This is something that's sometimes associated with a number of things, but oftentimes also associated with pseudotumor cerebri. And so if we see that, rather than just focusing back here and saying, well, this is a Chiari, I want to just go operate on the Chiari, it's important to recognize that there may be something too. This patient also was an obese female, so again, thinking about other diagnoses and getting the characteristic for what are these headaches like. Are they truly Chiari headaches, or are they maybe more of a constant headache and maybe more associated with pseudotumor? The treatment of pseudotumor cerebri is medical, acetazolamide or Diamox, which decreases CSF production and may work quite well. Ventricular shunting, again, just like we used in hydrocephalus. The problem with that is the ventricles are small, and if you drain the ventricles too much, they may collapse around the catheter and block the catheter so that you do not get any more flow. Lumbar shunting was popular because it's a bigger space. In these patients also with pseudotumor, Hal Recate, who's in the audience, we'll be talking to you next, has done some nice mathematical modeling saying that in pseudotumor patients, when the ventricles are small, the subarachnoid space is bigger. So there's more fluid to drain and less likely to be some problems with that, although there are more technical problems and more common shunt revisions with lumbar shunting. If you can demonstrate anatomically a narrowing of the intracranial venous sinuses, particularly the transverse sinuses, it's possible to stent them, to place an endovascular stent to open that area up and again get rid of that pressure gradient and hopefully then eliminate the problem. In obese patients with pseudotumor, the best thing they can do is lose weight. It's also one of the hardest things they can do. And so very commonly, this is where bariatric surgery comes in. And so it's very, very useful to talk about patients' weight loss. You can talk a lot. It's just physically very difficult to do and psychologically very difficult. But bariatric surgery, depending on what either their insurance requirements are to get to bariatric surgery, how much you have to have tried and failed, how bad their vision may be, because the primary and most debilitating problem with pseudotumor is vision and blindness. So we really want to protect the optic nerves. Secondary goals are with treating the headaches and all, but the vision is the primary thing that we really have to protect. So if we suspect pseudotumor in a patient with Chiari-1, you should include in the workup ophthalmology consult, again, document formal visual fields, so the amount of the world they can see, if there's any constriction of the fields, presence of papilledema, consider a lumbar puncture to measure the pressure, or ICP monitoring, where we place a little monitoring device into the brain and over time can do monitoring with this. So we can see what does the pressure run in different positions when they sleep at night, et cetera, and try to figure that. And also, also when we talk about, as part of the MRI scans in somebody like this that we're suspecting, doing the MR venogram to see what do the sinuses look like, okay? Failure to recognize this, just like in hydrocephalus, may result in persistent symptoms post-op and or CSF leaks. Very commonly, these patients, if they're operated on for Chiari decompression, may do okay at first, but in a period of a couple weeks to months, may represent with headaches that are going to be different than the classic Chiari headaches. It's just very important to think about it and recognize it. So again, we're just talking about some of these pathways. What we've talked about so far are the high-pressure syndromes, where if you think about the posterior fossa turning into the spine here is shaped like a funnel. So with Chiari, that funnel is getting packed tight and interfering with the flow here. So what we've talked about so far is things that cause increased pressure pushing down on this. I want to switch gears a little bit now to the low pressure things. So if you have a spinal fluid leak below this, or you have a lumbar shunt placed for pseudotumor or communicating hydrocephalus, you can also wind up with similar problems. So CSF leak has become more recognized over the last decade or so. It can be spontaneous, that just happens with no history of any trauma, or there can be a specific traumatic event that occurred. Iatrogenic is a fancy word that means caused by the doctor, but it sounds better than caused by the doctor. So we just say that's iatrogenic. So someone who's had, say, spine surgery, that has had a spine decompression fusion surgery may have an injury to the dura and may have a leak that perhaps was unrecognized at surgery, but presents then in a post-op fashion. Connective disorders that you've heard a little bit about so far, and we'll hear a bit more in the course of this meeting, Marfan syndrome, Ehlers-Danlos syndromes, are becoming increasingly recognized, are things that we're associating also with Chiari as well as with intracranial hypotension. I want to show how they may fit together. So symptoms of these are headaches worse when upright, improve with lying down, versus some of the high pressure symptoms which were worse, the opposite. CSF leak down below may cause the tonsils to descend and lead to Chiari symptoms. The MRI scan really helps in some of this diagnosis. The history is useful, but also the MRI scan. Classically, we'll see dural enhancement, so you need IV contrast for that, and brain sag, so that the whole brain seems to have kind of settled a little bit, not just the tonsils. So I'll show you a little of this here. These are contrast-enhanced MRIs, these two here, and you see the dura, the covering layer of the brain, lighting up white with contrast. And this can become even more significant over time, be thickened. And then this one is a little more gestalt picture, but here's a Chiari. There's CSF, or at least a pre-Syrinx state here. But if we look in front of the brainstem here, or at the base of the brain in front and by the pituitary gland, there's just not much CSF space, which would be white. Everything has just sort of fallen down in here. So this is something that we would look at and say, that doesn't look like there's adequate CSF spaces here. Maybe this is a intracranial hypotension. You can confirm a diagnosis with myelography, which is doing a spinal tap and putting contrast dye in, and either doing x-rays or CT scan to see, does it stay within the dural sac, or does this contrast extravasate to areas around it? If you can confirm a particular place, treatment with blood patching. So here you have your spinal needle in, but what you want to do is have a needle that is not inside the spinal fluid space, but outside the dura, so in the epidural space, and you inject basically blood or fibrin glue, which then solidifies and provides a seal. Ideally, you'll find a myelographic target to do this. If you don't, you can do a higher volume blood patch and hopefully stop it. But if you can find a specific leak, you can do CT-guided blood patching and try to seal it up with that. If you can find a targeted leak and the blood patching is not successful or possible, then sometimes surgery is indicated. That may be a situation of a postoperative case or a very persistent leak that just has not responded to blood patching. This is just an example of a patient who presented that Chiari that I showed you before. This was at presentation here in 2007. They underwent a series of blood patches, and then over time, then 2 years later, they have scans that now no more dural enhancement. And if we look at their Chiari, their Syrinx, and even the fluid space here at the base of the brain is much improved. And symptomatically, they were completely resolved. So here's someone who didn't need a Chiari surgery. They needed to basically fix the problem. So it's very important. Think about it, make the diagnosis, try to identify a leak site, and the targeted therapy is more likely to be successful than just shotgun therapy. Now we'll go to lumbar shunting, which is basically an iatrogenic CSF leak where you have a tube going to the abdomen, often performed for the treatment of pseudotumor or for communicating hydrocephalus, not so much for communicating hydrocephalus anymore. Some of these shunts didn't have a valve. They would simply be a very long, narrow tube which provides resistance to CSF flow, but not a lot of resistance. And over time, with overdrainage, then you would basically have the tonsils descend. Use of more modern, especially flow-controlled valve, not pressure-controlled valves, may help to prevent some of this. But this may gradually develop over time. It doesn't happen immediately after lumbar shunting. But worsening headaches, often occipital and worse with upright position, are kind of a clue to that. Literature suggests anywhere from a 15 to a 70% incidence of acquired Chiari, but only a small percentage of these, and again varies in the literature, 3 to 50% of these patients become symptomatic. So it's very common with lumbar shunt patients to see a Chiari, but many of them will not have symptoms, okay? But it's very varied in the literature. If the Chiari is symptomatic, first thing to do is figure out, do they still need that shunt? Some of these shunts were placed for a potentially reversible condition. Some of them were placed a long time ago for subarachnoid hemorrhage or like an aneurysm hemorrhage. They may not need the shunt anymore. Some patients who had a shunt placed for pseudotumor that then went on to lose weight may not need that shunt anymore. So the best thing you can do with the shunt is take it out. Then you can't have further shunt problems. Converting it to a ventricular shunt. So now instead of pulling down on the tonsils, you're basically draining the fluid above where that block is. And then if you do this, assess over time for resolution of the patient's symptoms. They generally respond very quickly. And then repeat MRIs to assess the extent of the Chiari. Consider Chiari decompression if the tonsillar herniation is persistent and if the symptoms are persistent. If you have this patient with lumbar shunt and acquired Chiari, and you simply do the Chiari decompression, you still have that lower pressure below. You're likely to wind up in the same situation again. And so we don't want to do that. So in summary, as a quick overview here, we've tried to divide these CSF flow disorders in terms of high pressure, hydrocephalus and pseudotumor, low pressure, CSF leak, intracranial hypotension, and lumbar shunting. We talked about the CSF pathways. The Chiari sits right here in the middle. So high pressure above or low pressure below is just going to exacerbate the problem that we have to deal with. Most importantly, when we're seeing patients with Chiari, and you've already heard this from several of the other speakers, it's important not to just hone in on the Chiari malformation, but look at the whole patient, take a detailed history. What are the headaches like? When are the symptoms worse? A detailed examination, papilledema, visual fields, imaging, not just of the brain, the spine. Consider contrast, MR venograms, cine studies to look at flow, and we've heard about that as well. Potential role of either lumbar puncture, which is a single point in time, or ICP monitoring. The advantage of this is I typically will commit to doing that for about 48 hours. So I want to see 2 nights worth of monitoring data to see if we see what are called plateau waves or elevated pressures when patients are sleeping. And also, we can let them be active during this time. During the spinal tap, it's very hard to have someone, you put the needle in, and then you tell them, relax. Don't think about the needle in your back. Nobody's very good at doing that. But if you put the little wire into their brain while they're asleep, and then later on they recover, it's not very painful, but we can get them up, we can get them moving around, and we can have them keep track of what is their headache like in a certain position, in lying down, standing up. We can monitor them in sleep. We can monitor them with all